public meeting. It has been recorded and will be available on YouTube, and it might even be being streamed as we speak. So can I just confirm that we are quorate at the moment, so we can go ahead? Thank you. Make the normal statements about declaration of interest. Does anybody have anything on the agenda which they recognise as a potential conflict? Good. And if during the course of the meeting any matters arise in which you believe you have an interest, or any other member of the committee has an interest, can you please indicate immediately so we can make a decision, discuss and make a decision on how best to make progress? Thank you. Welcome on board, John. I've just made the usual statements about declaration of interest. Do you have anything to add to today's agenda?
No, from the agenda I've seen, except that obviously my declarations are logged in the publicly available register, and I, as well as being the Chief Clinical Officer, work as a GP in Oldham, so several of the practices are part of the group that I belong to.
Thank you very much.
Okay.
Thank you very much for that. Can I just remind everybody, as Mike has just done, to put the hand up and to put it down afterwards so that it doesn't confuse me, and I'll try and deal with them as I see the hands come up. Mike's put his hand up. Mike.
So we've never formally said it in this meeting, I think, but I think we should do, because John just has a habit of hiding his talents under a bush somewhere. You know, one of John's many talents, which he's just declared an interest on, is being part of the National Programme for Health Inequalities, which of course is a significant issue for Oldham, and the work that John's done over the past couple of years in exception coding, looking at disparities, tackling health inequalities, is an extension now recognised nationally, and whilst he's kind of very briefly whizzed over his conflicts of interest, that's a relatively new one, and it's something we should be proud of as a system, but no, something John's going to be amazing at, so I'll say that one for today.
Yeah, I think it's worth noting, John, as you said, is very modest, but we all recognise and are grateful for his input, because we will be amongst the first to benefit from the outputs of his work, as he's a local chap. Thank you.
And thank you, Mike. And just to say that it wouldn't be possible without a team and a collection of over 30 GP practices that want to work in the best way and make the NHS best where it's needed most. So you can be a lone ranger and burnt out, or you can be enthused because you've found your medical, clinical, spiritual home amongst some excellent leaders on this call. And you know, the GPs in Oldham, quite rightly, and we often sit here problem solving on this committee, but there has been a sea change, and thousands of families have a better offer now because of what the GPs have done. So thank you.
Thank you. So can we move on to the minutes of the last meeting? I'm hoping that everybody's read them. I don't want to go through them page by page, but I do need to ask, are there any points or issues, corrections, admissions or discussion points that anybody wishes to raise? There's a couple of things just for clarity, Nicola. In the minutes it says that at 3 of the practices they were to produce a plan, an action plan, and present them. Have those action plans been received from the village, Werneth and Medlock Vale? Excellent.
Yeah, they have. Yeah.
Thank you very much indeed for that. They were important steps in the progress of those particular practices. So thank you for that. So we can move on to the next item then, which is Nicola. In fact, it's you all afternoon, isn't it, Nicola?
It is, and I'll
we'll go dictated by you so that you're not under too much pressure.
Okay. The quality assurance paper, just so everybody's aware, and just for a reminder for anybody that is watching this, we have as a CCG a quality assurance framework that we work with all practices on and work with CQC. This is not a punitive framework. This is very much about support. So the things that you'll hear in this paper is about the team being very supportive to general practice. And I think, as you see in the later appendices, there's actually all of our practices, barring 2, are good, and we have 2 now that are exceptional, and it is because of the work of the team and very much around this framework that has got us to that position. 3 years ago we certainly were definitely not here. So As we start the beginning of the quality assurance paper, the first two are an update around the CQC published papers. The first one being Moorside. So they had a comprehensive inspection back in August last year. They were rated inadequate. We put support into that team, and breach notices were late, unfortunately, in coming in from the Moorside practice. So that left them to receive further breaches because of late submission. They were inspected again back in November. Again, the report for December 21 noticed that they were, although made improvements around appraisals, policies and recruitment, they still remained inadequate. We have been out again this month to work with them as a team to get them ready for the next inspection, and CQC are due out this month to go back and to see how they have progressed with those breaches since December. The team at Moorside feel that they are in a better place. I think very much they've taken this seriously, and that a lot of intervention from the whole team has gone in, and I think that we should be seeing a much improved CQC report, and that will be reported at the next Primary Care Commissioning Committee. The next one is Failsworth Group Practice. The committee and members will be aware that due to a report and a CQC inspection back in December, the report landed with us in January, and we took a decision as a committee to terminate the contract due to concerns over patient safety. Notice was served on the 26th of January, and a full termination of that contract was the 28th of January. We've been working with the caretakers, which is Quayside Medical Practice, to work on all areas concerned and to review the quality assurance of the patients, and to make sure that the patient list is safe whilst we disperse. That's continuing, and the patient list is, I'm pleased to say, safe and being supported in order to find new GP provider. The next update is around St Chad's. As the committee and people will remember, on the 5th of January, the partners of St Chad's served notice to us as an organisation on their PMS, Primary Medical Services contract. The practice had aimed to close on the 31st of March, which is in this paper. We now, and I can update the committee as today, it's unlikely to close until mid-April. They did have a notice period of 6 months. We were all aiming to close within 3 months. That isn't the case now due to the nature of the patient dispersals, and we want to make sure that patients are dispersed safely into new practices, and so therefore it's likely to go and remain open up until April. The team are working with the partners there to ensure that the practice remains open, the doors remain open, and again for any public that facing, and certainly for Timor and from an LMC perspective, as I know that they're on the committee today, that very much that has been communicated to make sure that the practice remains to offer to all registered patients until they close appointments and medications as required. All of the patients for Failsworth Group and St Chad's have been fully communicated with. They've been supported. We've been working with other agencies and partners to support more challenged patients to be able to provide and register elsewhere. We've done support for our GP practices across the whole of Oldham who are receiving new patients, and so their patient lists are going up because this is a challenge time, as we all know, and so the team have been out working with all concerned to make sure that this is done safely, as we know that this is unprecedented. Other practices that the team have been working with since November: St John Street, Oldham Medical Services, Oak Gables, Hollingwood and Royton Family Practice, all of which the prioritisation of visits has been based basically around the scorecard, which is in Appendix 3, support around managing complaints and challenges from PPGs and any soft intelligence. Equally, this is about practices coming forward and asking for our support, and I think if we remember when this went live 2 years ago, that wasn't something that we ever thought would happen, and actually practices are now contacting us to say, can you come and support? Remember, and I think it's really important for anybody watching and committee members, the scorecard often reflects deprivation issues and challenging patient lists. This is not about the quality, not always, or poor practice of the patient, of the GP practices themselves. And that is really important because you can often look at a sea of red and put that against the GP practice, and that isn't. This is the absolute positive thing around the quality assurance visits. This is about us supporting to deliver and get the strategy right across Oldham to be able to, for us to look at inequalities. And I think that's something that we can really positively say is coming out of that. St John's being one of them, there's definite improvements around diabetes and being able to work with that patient list. One thing that has been really celebrated from the team is that the work at St John's, they have taken an approach of change one thing, this initiative that is where all practice staff have had a proactive focus on one area to prove outcomes for patients. And they've absolutely been congratulated on that, and they've gone from rated 36 to of 39 of 39 to 29, and that's a real improvement in a very short period of time. I'll pause there because I can see Mike's got his hand up. Is it about that? Sorry.
Yes, Mike. Do you want to come in now or just later?
I'll come in at the end. I've got some comments I want to make on the report itself.
Okay.
Okay, thank you. Nicola.
Oldham Medical Services, certainly they've had the challenge, and they have been very open with us around their increase in lists around economic migrants. We're working with them around education and how we can improve that. There has been some improvements made around access, and they've been able to work on acknowledging that they have a lot of do not attend DNA appointments, and so they've opened on Saturday mornings and they're working to improve around vaccinations and immunisations. They've also done some recruitment around coding, some work around improving their recruitment and their coding. There is some more work that needs to be done, and so the team are working with them, and you referenced this at the beginning, Chair, around the improvement plans. This is one practice that's been asked around that for a 3 to 6 month improvement plan, and again the team are working on that. Oak Gables, again, somebody that, you know, this is a practice that's middle of the pack. They were 16 rated on the scorecard out of 39. They came to our attention and we've approached them because they've had some significant an increase in complaints, both made to us, elected members, and to the practice themselves. There's been some noted social media pressures, so we've gone out and supported them along with the PPGs. That's helped the team and the staff in the practice gain some insight into the issues. I don't think we're over the challenges there quite yet, but we're certainly working with them. They've had some workforce issues, but they're confident that they'll resolve it. And again, as with other practices, we've asked for an improvement plan so that we can work with them, because again, it's about assurance and the safety and quality of patients. Collingwood was our next practice to do a visit with, and that was on the 6th of January. So this is post Christmas. I think there was some noted areas of challenge due to the list, and they always have had a challenge of their list around childhood IMS and VAX updates and people taking up. So although the clinics that the practices have booked and have had on offer are full, it's not perhaps impacted the way that they wanted to, so they're looking to understand their data and work in a different way to be able to offer some of their population a different way to have the immunisations. I think a lot of this is about education. The practice list has a lot of the Romanian community on there, and so we need to work with them to understand that actually is an important thing to get your children immunised and vaccinated. So that work's been done, and again they've been supported on that. Equally, they've had some readmission concerns, and the practice have been really proactive looking at the data as to understand why, because this is something new for them. So again, we're working with RBI team, the primary care team, to look at that. and they have been working with a new pharmacist to work out how they can look at their prescribing habits, and that's something certainly when we look as a wider CCG, this is something that we're looking to work with them on. Royton and Family Practice, they were seen on the 8th of February. I think it's fair to say there's a lot of work that's been done with this practice working, and this was at the request of the practice again over the last 12 months, looking at how they work with their patient groups and support access. There was a lot of complaints, a history of complaints that had gone through to CQC, but the practice has really taken on board some reviews and some improvement plans. They've increased workforce. They're looking to continue to keep that up and do that more. Their next priorities, they've been very proactive in communicating around frailty and meds optimization. And again, with the quality assurance framework, we've asked for some more support and a plan, so we'll be working with them, and that's about it. A whistle stop tour, unless anybody needs any more details. I'll pause there. Thanks.
Thank you very much indeed for that. As you said, that was a really, if it's possible to have a comprehensive overview, that was it. Thank you for that. Mike, you wanted to come in, I think.
Okay, thank you, Chair. Probably not all to be answered by Nicola. I think there's an input from a number of people, notwithstanding people's conflicts of interest. I recognise them. So it'd be really helpful to know from Hollingwood in particular, if they've got any estates issues that the CCG needs to support them with, what would they look like? I noticed there's a reference to nursery provision in there. It'd also be really helpful to understand what we're doing to improve I think it was prescribing the medication rates in that particular practice, so any insight to that would be really helpful. Turning to Oak Gables, I do think we need to be a bit more candid about all of the issues surrounding Oak Gables that I'm aware of. But fundamentally, when do we think that the tightened level of infection prevention and control consequent to the COVID pandemic will actually be managed in a more moderate way by Oak Gables practice, given that they continue to insist on their practice door being locked, access only being through an intercom, and people waiting outside in the freezing cold and the pouring rain, elderly. And there is a very big difference between the other practice in that building as well that does not agree with that approach. And then finally, it'd be really helpful to understand how the Royton practice are dealing with the continuing pressures around telephone access for their patients, and when that will be resolved more satisfactorily, accepting the fact that they've made a lot of progress in recent times, but there are still complaints that I'm aware of. So a fair amount of issues there, which would be quite helpful to understand.
Right, that's really interesting to hear some quite concerning questions around the practice of some of the practices, which needs to be resolved quickly and urgently, I suggest. I see Andrew had his hand up first, if I may, Nicola.
Yes, I'm here in my LMC role. So first of all, am I allowed to ask questions? Thank you, thank you. The first thing I'm going to say is thank you very much to you guys, and Nicola in particular. Last year was a very challenging time for the surgery, and really the change was phenomenal. Just to give you an example, in May last year we had 85,000 phone calls, which meant that every single patient we had wanted 4 appointments in 1 month as opposed to 4 in 6 months. It was out of control, and it's completely changed, so thank you. We had a meeting yesterday with all of our clinical staff, and we've been looking at face-to-face appointments, and I have buy-in from every single clinician that there's going to be a lot more face-to-face appointments routinely. The guidance is ideally, face-to-face if necessary, but a lot of people just want it at this stage. So we're working on that. I had a query, and it was an estates issue around Failsworth. I'm aware that with the closure, there's a couple of ex-partners within Failsworth who have their names still on the contract, and they're very concerned over what that means for them. And I don't know if this is a forum in which Sorry.
No, I don't think we should. Can I just interject there, please, Andrew? Remember, I don't think it was appropriate to have that discussion in this form. And wearing your LMC hat, I get, but I think you need to take that discussion offline, please.
Well, indeed. Thank you. Thank you for that feedback. That's wonderful. But yes, thank you very much for last year and for all the support. And hopefully we shall be better moving forward.
Thank you, Andrew. Nicola.
So I didn't write all of the points down, Mike, so if I don't cover all of your points, then please let me know. Part of the quality assurance framework is looking at estates, because we know that from if we give good environment and we are able to support practices within positive environments, then services and patients will receive an improved care. So when it comes to Hollingwood and other GP practices, we are working with them to identify, and we know that, you know, in reference, Andrew, it is better that we talk about, you know, very specific things outside of here, but we are working with all practice to look at the most appropriate estate. So I think, you know, unless there's anything else on that, Mike, I think that was the estate issue. Oak Gables, we have had some challenges with Oak Gables. Part of the reason why we went in and supported them, I think there are some challenges that we need to work with the practice, certainly when estates are combined, so that there are two practices working out of one building. Just to be clear, that this is around one practice wanting the front door to be locked and closed, and one practice believing that that isn't the most appropriate and to have it open. We're working with both practices to make sure that patient access is appropriate and right and proper, and that we don't have vulnerable people waiting outside. This isn't something, and we haven't got NHS England in the committee unfortunately today, but just so members are assured, this isn't something that we are contractually able to hold with the practice. However, Andrew, from an LMC perspective, we may well work with you to look at how we can get two practices to be balanced and have a front door open, because that is a patient right. So that's that part. Two hands have gone up. Do you want me to pause on the?
Yes, I think so. Majid, you were first, weren't you?
Sorry, I wasn't responding to anything what you were saying, but I'll just put my hand. Is that okay? So I don't want to spoil the flow and thing. Just a couple of quick things. First one is to really acknowledge the progress that has been made around the practice assurance visits. Here we were some while ago where there were some concerns about what are the purpose of the visits, are they really going to benefit, are they punitive, etc. And here we go, a short period on, and people are asking for them proactively, so real value in them. So really good work by the team on there. The question I was going to ask, when you spoke about immunization and lack of within certain sections of the community and stuff, and I was just wondering if we can link in with the sort of broader system working and see if there's any learning from the vaccine uptake work, and if there's anything we can do from there, and any learning from there.
So there very much is, and I'll bring that into the COVID vaccination and flu update, if that's okay, Majid, but there very much is some learning that we can take.
Thank you for that.
Yeah, thanks, Chair. And to make a couple of general points about the paper and about GP quality, and I suppose, you know, Andrew and I being here does give the committee the temptation to be able to dig down deeper into some of the practices mentioned. I'm not sure about that as a process, so I'll steer away from specific points if that's okay at the moment. However, you know, let's get back to the CQC reports. All quality measures are proxy measures. They don't actually tell you, as Nick has eloquently said, the full picture of the quality. And so even in some of our dashboard practices where there's a lot of reds because of nursing and pathway and managerial churn, there's actually a lot of satisfied patients who are being seen. And I think, you know, some of our smaller practices actually give quite a personalized care, so they might appear quite poor on the red, but actually the patients will, if you look at the patient survey, etc., there's other data points. However, do we think that the core bits of CQC are important by their proxy nature? Yes. Do we think that 4 years later we have better HR processes across the patch? Yes. That means that our staff are going through the right employment checks. That's demonstrably clear. Do we think the safeguarding processes across the patch are demonstrably better, keeping our patients safe? That's demonstrably clear. Do we think that we are more of a learning system? So can we evidence that our GP teams across Oldham, if a mistake happens, they learn from it and they change and they are transparent about it? That's also demonstrably clear. So, we like the proxy measures of the CQC because I think they are real and they are important. We have some other proxy measures as well. So that we talked about the patient survey a couple of times ago, that actually shows that for all the frustrations we have about access in general in Oldham, patients say that they get the right care at the right time, and that's better this year than last year when we were deep in the pandemic. And in terms of ease of making appointments, I don't think anybody is satisfied in the whole system about the amount of access we can provide. But the fact of the story is that patients report that it's easier this year than it was last year. And it's a difficult system. So elsewhere, away from this committee, the national target for the national target for hospitals, which used to be done and dusted by 18 weeks, has stretched out to 104 weeks. That target has to be attained by the 1st of July. By the 1st of April next year, that 18-week target is now reduced to 78 weeks. And then in 2 years' time, we're going to try and get it back to 18 weeks. So we shouldn't be surprised that general practice is then struggling to do its 10-day, 2-week targets for access if elsewhere in the system an 18-week has gone to 104 weeks. And I think the primary care team and the GPs of Oldham have done really well at keeping themselves available. And the data points I would quote for that are the patient survey. But we have another data point that isn't in the papers today, but ever since we've had to manage, regrettably but necessarily, patient dispersals and changes of list, we have tracked the flows of patients, and it might be useful to discuss that in future meetings, because whereas the journey of one individual patient and doctor doesn't tell us anything, when you start to put dozens of patient movements together, it's actually quite a sensitive test to tell us which practices are thriving. And so as much as we've used that data set to see patients move from Donald Wild, move from Failsworth Group, move from St Chad's in a managed way that we have described in this paper, what's remarkable is the lack of movement and the stability in the other remaining practices. So I would give that to this board as a measure of, and to people who are watching, as another good data set, as a proxy measure of the quality of general practice. Although we have these issues of phones and various other things, we're not seeing patients fleeing practices because they don't feel that they're thriving. And that is a different picture than we had 4 years ago, a different picture than we had 3 years ago pre-pandemic. And so there is a stability that is there in patient experience through the survey, through patient movement, and then through the emergence of this much better CQC picture. So, and then I think we do have an understanding of problems. And just to reiterate what Mike and Nicola have said, that I certainly see a thoughtful and a nuanced dialogue happening at Oak Gables and the village about the door, and I'm sure we'll get to a good resolution about that. And I think Oldham probably leads the way in terms of numbers of GP practices that are open and trying to get patients through the building. There are other places around the country where there is more than just one closed door across the patch. So commend the paper, commend the work of both the team and the GPs, and we are in a different place. And this next year, moving away from the pandemic, I think we know the to-do list, and we have the energy and the data to move forward. Thank you.
Thank you, John. You made some very valuable points there, which were important to note, and I'm pleased about that. Thank you very much. Nicola, I think we're back with you still.
Yeah, so if we're okay, we'll move on to the PCN update paper, if that's okay.
Yes, please.
So I won't go through the detail or the history. Everybody knows we have 5 primary care networks across Oldham, and they are all working together, and we are supporting them as a CCG as we move into the new world, around how we work for them on a new operating model to help them deliver their new contract. This is very much, and we work with them as a collective leadership team as well as a primary care team and a wider team about how we effectively deliver sustainable services that are integrated across all of our providers in Oldham, and I think that's really important. So the paper looks at what the PCNs have done, the local enhanced service, which is the population health management scheme that we've got, and the winter access fund. Things are going really well. You can see that we're working on improving access, and that's just been covered in detail in the previous discussions. What we're looking at around the population health management is how we get all of the practices within each network to come together and have a standardisation around 2, which is diabetes and respiratory, that we've given to all networks. We know that this is an area where we collectively need to improve our outcomes for patients, and then the PCNs have been able to work together and look at another 3 areas that they want to locally determine. I meet with them monthly along with the primary care team, and we talk about how that is going for them. You can see by the paper that they are improving in areas, certainly around how they get patients to come in and access services and standardisation of the care around the long-term conditions. This is something that is very innovative. It isn't a normal locally enhanced service, but actually what we're getting feedback, having had a lot of resistance from PCNs and from practices, is actually they are now starting to come together and talk, and if nothing else, that is absolutely something that will bring us and reap of benefits moving forward. And as we certainly get towards the end of this financial year, having an operating model that we can say collectively across Oldham that we're all working towards the same aims, and we are very proud of that. I think that's been something in the Winter Access Fund that has been nationally driven, but I think if we hadn't have done the previous work with the PCN contract and the population health management enhanced service, that if and when we got the Winter Access Fund, if we hadn't already laid that baseline, I don't think we would have been able to get to the point we've got with improving the access over the winter. This has got a huge national focus on it. In everywhere you look, certainly, you know, nationally, politically, there's a lot of drive at a time that's been really difficult for primary care, and we certainly took that approach as an Oldham leadership team. We've took a different approach, as we often do in Oldham, compared to GM, and we've looked at targeting cohorts of patients and increasing access, as opposed to very wide open reach, you know, anybody is able to come in. So North are looking at shingles vaccinations and supporting patients. They have high levels of shingles and diabetic foot clinics. In South, they're looking at spirometry and acute access with MSK services. West are focusing very much around their long-term conditions and acute conditions and improving access for those patients. And Central are working around immunisations and vaccinations, again, a theme that's running throughout all of the papers today, and cytology clinics. And East have improved access for same day, which is something that they've not had. The data is currently being collated, and the PCN dashboard will be available next month. So I think, you know, we'll circulate that to all of the committee members, and that'll be something live for everyone to look at. I think that's going to be really important as we start to overlay all the data again that John's just talked about around the soft intelligence around patients moving. Plus our long-term conditions that will help us as a system start to improve our strategy. And then the paper, you know, quite rightly acknowledges the risks, and this isn't something that's at the bottom of a paper to be ignored and something that, you know, we overlook. Very much the risks are workforce. We know workforce is stretched. We know that we've lost a lot of staff in movement over the pandemic, and certainly we weren't you know, the highest with recruitment. Pre-pandemic backlog and people that have not had the access that they would have had, our vaccination strategy, and then again estates, which has been a theme throughout all of the papers, the estates to deliver all of this, because as we increase our primary care services, we need to improve and grow our estates in order to deliver. And that's a whistle-stop tour of that paper, if that's okay.
Any questions, Mike?
So two to start with. When do we think South will get on track with extended access, because it's currently shown as amber? So that's my first point. And then second point is, not, I can't get a feel from it from this paper, but from memory, every PCN is not where it needs to be for the R's scheme, and that could be a wrong statement. But if it's a right statement, when do we think that position will be recovered, given, you know, we've heard already what are broadly described as capacity issues around access in primary care? We very much need these R's to come in place to take some of the pressure off our very hard-working and stretched doctors and nurses working in primary care. Thank you.
Thank you, Mike. We'll come back in a second, Nicola. I think Derek wants to raise some points as well. Derek?
Yeah, very detailed report and full of aspirations. So I've got two questions, if I may. On a range of a score of 1 to 10, 1 being poor, 10 being very good, where are the primary care networks as a whole, not individually, but as a whole within Oldham, where do we think they are in terms of setup and ability to deliver? And the second question following on from that, where do we think they're up to on the same scale in terms of delivery of the outcomes that we expected them to be delivering at this moment in time?
Thank you, Derek. Nicola, do you want to respond to those first? Unless, John, do you want to add to those, or is yours a separate issue?
I just wanted, bearing in mind that Marion's not here, was going to give Nicola some support with Derek's, with answering Derek, if I may. But
okay, but let Nicola
call on me, Chair.
Yeah, you hold and let Nicola lead on that. Nicola, would you like to respond to Derek?
Right, okay, Mike, I've not forgotten. I've got fingers on the points of things you want answering. Derek, there's something called a maturity matrix for all PCNs. It's something that we work with them when we would meet with them on a monthly basis to go through how they are and how they're developing, and also about how they feel they are. And I think 18 months ago we were probably in a place where they believed they were very mature, and actually the work that we've done with them as a system and included primary care voice throughout all of the conversations we have, I think we're very much balanced now of saying they're not fully mature, but I don't think any PCN would say to you that they are anymore. We're very much on a kind of it's on a 1 to 5 basis. I think we're 3s and 4s in the main. So some areas we're very mature and we're able to deliver against, and other areas we're not. And so that is why we spend a lot of our time working with them around how do they grow as leaders and as networks, because this is very much what has delayed us when Mike's point around the R's delayed us in able to get over some of the challenges, because it is very much about recruitment liabilities and how do they as practices, as businesses, as individuals and as networks start to grow. So that would be the kind of overview of that. I'm sure John's got more to answer on that.
Thanks, Nicola. I thought that was a good comprehensive answer. John, come back to you in a moment, Majid.
So I do love a data evidence response. So thank you very much, because I would have not referenced the maturity matrix, but yes. So there's an empirical evidence. My addition to that report was going to be to benchmark about where we really are in GM and nationally. So there are a couple of exceptional PCNs across the nation who have benefited from the geography landing really fairly and where they've historically been. But the vast majority of PCNs are roughly where we are in Oldham, if not slightly behind. So there's going to be a GM PCN meeting later on this month. They are casting around for best practice. they have 4 examples in GM of it actually being beyond the concept and the governance arrangements to where it's actually working. We will know as a committee, and the public will know that it's working when the pipeline of employment starts to drain the end of the available workforce. And so, you know, everybody wants a mental health worker. By the time we discover that we only have a workforce for 10% of the want, that'll be when we know that we've reached a level of maturity. And we are starting to get there with pharmacists and a few other specialities, that the ambition of the PCNs, the functioning of the PCNs is already running up against a limited workforce. And what we don't want to do then is have a merry-go-round of people just never doing the job, but forever being poached by the PCN up the road for slightly more money. So I am happy where we are in respect of you know, the GM picture. I'm not happy where we are as the PCN CDs would say they're not happy where they are in terms of where we could be. But there's been a pandemic, and it's this 12 months. So just when the transition lands, Mike, as you're well aware, this is when we need to be getting the employment offers and the transparency. And we've worked really hard to get the 5 leaders, and we would commend the 5 leaders to you. They're starting to work together again. There's loads of issues, but we are definitely in a much healthier place than we were 6 months ago. But there's so much work to do, and I'm looking to this committee to support that work. And just to highlight, the GM are just starting to do their best practice, but at the moment, and I expect that we'll be contributing to that work shortly. Thank you.
Thank you for that, John. Majid, you want to come in?
Yeah, just a couple of quick things. So really good to see the priorities by PCN, so priorities that are relative to the places and communities that those PCNs are part of. Just thinking about stretch and sort of measurability of some of those priorities. Some of them say, for example, increase or reduce amputations, for example, but that could be reduce 1 amputation. It'd be good to see if you can get more of a feel, more quantifying it, not to the exact number or a target, but just to get a feel of the difference it's going to make. And then the second thing linked to that is about what role do the patients and communities themselves have in determining some of those priorities through the patient participation groups, etc.
Thank you, Majid. Nicola, your hand's up. You wanted to come back?
I just want to answer Mike, and then I'll answer Majid if that's all right.
Fine. Yep.
Okay, so Mike, there is South and Central that are both showing amber from an access perspective. I think Central is looking at how they stabilise. If the committee members, they went from 2 PCN directors into 1. There was a disparity in how the PCN worked before the current leadership, and so they're looking at equitable delivery across all of the practices. And I think that's because it was heavily weighted in one part of Central rather than both, and so there's been an equal baseline remeasure around access, so that's why they're shown as amber. The amber in South is purely due to the patient moves and due to the 2 practices that have recently closed. So naturally access has reduced, and that needs to be rebaselined. I would like to say the next time we bring this report into the committee, you will have that and all will be showing as open access. With regards to your question around ours, Mike, I think now we've got a more stabilised, and as we've grown in maturity from a PCN perspective, the R's roles are starting to take up. The committee may or may not recall, this has been something that when it first came out is a significant amount of money, and there was a big ask around all PCNs to be able to employ these roles. There was no flexibility. There is now more flexibility, as I think nationally they've realised.
Can I just, remembering that this is a public meeting, we've slipped into using lingo that may not be understood by members of the public. So could you just explain what R's are, please?
Okay, so apologies. Apologies. It's in the paper. It's the additional roles and resources services. So these are additional members of staff that would enhance a workforce within each primary care network.
And this is funded centrally, not out of our current budget, isn't it?
No,
No,
this is a nationally led piece of
Yes.
work. There was a lot of restrictions on how we could or could not employ these individuals. There's now been a significant flexibility, and we've been really successful. So Pennine Care Foundation Trust, who's our mental health provider, has been able to work with all of the PCNs, employ mental health workers and redeploy them back into PCNs. So we've done some work around how we can and can't use the money in order to get the services within the PCNs. So I think that answers both of your questions, Mike. Majid, so from a point around how patients are having a voice within population health management. This isn't something at the moment that we've supported or encouraged, and the reason being is, if you recall, this was a baseline year to get practices talking together. So this was very much about aligning the work, and then we will lead into having a population voice. This is very much about practices weren't sharing data within each PCN. They now are, and they're getting to a point of understanding that. When we start to look at, for example, and you said reduce amputations, very much around that, this is very much about, again, data, understanding, practice level data, stuff that from a CCG perspective we don't see. This is practices understanding what their baseline is and standardizing how they record, how they code. And so therefore you will see that, but it will come in next iterations as opposed to, because we don't know how many, this is about data capture. If that's okay, I think that answers both questions. Thanks.
I think Mike wants to come back in. Mike?
Yeah, so this is just a reflection more than anything. I think we're in slight danger of ignoring the fact that we're kind of not fully out of a pandemic yet. You know, there are still 10% of our inpatient bed base across GM is people with COVID. Still 1,000 people off in the NHS work absent with COVID. Some of them are in primary care. So I don't want us to lose that. This report's a very different report. We would not have got to where we got to with things like the vaccination programme without our primary care networks. So I don't want us to be too hard on them. I think, you know, questions about how do we get back on track are the relevant ones, because we were blown off track from a pandemic point of view. So the fact that we've got this report here today, I very much welcome, but I do actually want us to celebrate the fact that our PCNs have been nothing short of flipping amazing through this pandemic. The way they've come together, we can criticise all around the edges of little tiny things that we could have done differently or better. The fact that we're now kind of having a different conversation that's not about, you know, vaccinations. It's about actually how do we start to deal with the underlying population health challenges? How do we recover services? How do we get back onto a recruitment bandwagon? I think are, frankly, the right questions to get to, and the report's great from that point of view. So let's not also lose the amazingness that's happened over the last 2 years. Thank you.
Yeah, thanks for that, Matt. In fact, just reflecting at the stage rather than at the end as well, I think there are two very sea changes that we've seen. One is around the practice assurance visits and the positive impact that they have, and that positive impact translates into immediate patient care, which is really important. And I think Mike makes a point that the system was blown off course by a full force hurricane, and even during that, the core business, and I hate to use healthcare as a term business for healthcare, but the core delivery of health care to the population of Oldham has been nothing short of outstanding, and that is due to the primary care team based at the CCG and also the people out in the field managing the process. So I think without wishing to keep re-emphasising these things, I think Timur is wanting to come in. Do you want to sort of say something particularly relevant to the conversation, Timur?
Yeah, I hope so, Chair. Sorry if there's connection issues. I'm just on the school run. Just in terms of, there's a lot of talk there about patient and public engagement. It was suggested to us a couple of months ago that we take part and lead with colleagues in the primary care system around an audit of the PPGs across Oldham. So I don't know whether it's relevant to bring that up right now, but we'd be very interested to pursue that. I'm conscious that the wider network for PPGs as well hasn't obviously met or been doing any business for the last, well, key part of the last 2 years really. So just like to see where we're up to, because I understand there was a practice in terms of CQC picked up some issues around a PPG not functioning or not being fully utilized, and so there's conversations had with us from the CCG to say that would we take part in an audit of PPGs across the borough. So I just thought I'd bring that in, given we're talking about public engagement.
Right, thank you for that. I think Mike summed up very quickly that we can get bogged down with minutiae, given that we need to get a major ship. I didn't mean that critically, Mike. Pointed out that we mustn't forget that we've got the ship back on track. It might be a bit battered around the edges, but we're back on track. And I think Tamo's touched on one of those back on track subjects that we can take offline tomorrow and discuss elsewhere, because we've got other things on the agenda which we need to press on with, and what you're talking about needs a detailed discussion, which would perhaps be inappropriate in this format. But if you'd like to contact me privately or outside the meeting, we can have a chat about it. Thank you, Tamo. Back to you, Nicola.
Thanks. So the next two item agendas are around the COVID vaccinations and the flu vaccinations, and both the presentations. So if it's okay with you, Chair, I'll talk about the strategy and how both campaigns have run, rather than going through detailed slide by slide. That's for the committee and any members of the public to go through, and I'm happy to take questions. I think overall what's been reflected in this meeting is that we have absolutely stood together as a system. We've been able to offer really good access for all of our population, and for those that are outside of our Oldham footprint. We have had and seen many people from our bordering areas come in and utilise our services, of which we've stood together with GM and been supportive of doing that. I think that, you know, it's shown that we've been able to offer a system response, so we would not have been able to do this without the support of the Royal Oldham Hospital and the NCA colleagues, as well as our primary care networks and each individual GP practices. We've been able to offer extended hours that have been very different to the offers across different parts of GM and nationally, and very much from our voluntary care faith sector. Without them being part of this programme and supporting us in door knocking and working with our population, we certainly wouldn't have been able to access and vaccinate a lot of our population. What we have, and what you will see from the data, deprivation again has really caused us issues. Although we are deemed from a statistical perspective to be one of the lowest in GM for uptake, actually the deep dives and the work that we've done, and we've worked with the national team and our local NHSE England team, is that actually we've been able to get into areas of our population that others have struggled with across GM. Some of our reasons for low uptake has only come to our attention as we've started to build our data sets, and this is very much around how Marion, who's our head of primary care, and Claire, who's our nurse lead for the CCG, as they start to build the strategy around immunisations and vaccinations, when we overlay the data, it's a household issue, multi-generational issue. So when we look at the children that aren't taking up, that we've talked about in previous papers, aren't taking up the childhood immunisations, they belong to family networks that aren't taking up other flu vaccinations and COVID vaccinations. So we need to overlay our data sets and start to think about a wider strategy, so we're not having COVID vaccinations, flu vaccinations and childhood vax. And actually that's something that we are going to need to work with our GPs for, because of the way the contracts and the funding flows work for vaccinations. This is something that we're going to have as a strategy that everybody signs up to within our system in order for us to fight and improve our points. I think the one point before I stop that we've seen an improvement with, which actually none of us thought that we would, compared to other years, we've improved our flu vaccination uptake in those women that are pregnant. And that's not something that we expected, but we have certainly seen this year. So I'll stop there and take any questions on that.
Thank you for that, Nicola. Anybody else, any questions at this point? Excellent. That's an excellent report. Thank you very much indeed for that. I think that brings us really to the end of the papers and items on the agenda. Just a discussion perhaps about any risks that we've identified that anybody would like to highlight. Sorry, John.
So I've talked elsewhere about elective care recovery in long-term conditions, and the fact that primary care, one of its amazing things it does is prevention and stabilization of long-term conditions. So I won't repeat myself, because I think we have highlighted that risk, and we have plans in train. I do think the public engagement is an interesting conversation, because of course the vast majority of our patient participation group PPG members were the very people who should be shielding, and therefore, you know, a lot of that work sort of evaporated because there was a sweet spot of shielding and lack of IT. So I know practices who heroically tried to keep going with their PPG work even amongst their shielding PPGs, and discovered that they just didn't have the IT. And quite frankly, when you're trying to do the job and trying to do the vaccination program, etc., then, you know, that's why I say that they were doing really well trying to get that work going. So I would welcome that refresh that we've discussed. I fully understand that last time we discussed it, you know, events have carried on changing, and the government hands down priorities, and at no point have any of these priorities come down about PPG work or about engagement work or any extra funding for that work. And I'm sure Andrew would agree with me that as much as we want to do it, we're being asked to open on Saturdays and Sundays and everything else, but not the PPG work. I still think the majority of practice managers and GPs in Oldham see the value in that work. And certainly I've been in contact with some GPs who are trying to relaunch that work and do it in a different way, and trying to do open forums. And then those teams who speak to me enthusiastically, I find myself emailing them the next day going, by the way, can we talk about your vaccinations and your IMS and your access and your phones and your digital and everything else? So I just think it's good that we keep talking about it, Graham, because I don't want it to go away.
Oh, no, it won't.
But just be mindful that the drivers for it are vanishingly small. It's the goodwill of the workforce. It's the desire for people to have a community service that reflects them. It's the good work of people like Tamura who keep us on it. So that's my risk in terms of I can see a definite plan for everything else, and I can see that we've stood up this work 3 times at least in the past year, but each time the capacity for it has been subjugated elsewhere, understandably, and it's absolutely so just to reassure Tamura and people on this meeting, it's absolutely not a it's not a desire for us to not engage with the public, and public and GPs are absolutely showing us that there is good examples, and I suppose GPs are speaking with members of the public 1 million times a day across this country, and so you know there is that engagement, but it would be nice to get the formal stuff a little bit firmer. That was my only thought. Thank you.
It's one of the wheels to put back on, isn't it, Mike?
So I can't help feel that there's a real danger that we just kind of take a big intake of breath and say that's it, the pandemic's over. I'm going to say the pandemic's not over, but there's a psychology that people think it is, and actually what's coming at us is a tsunami of other problems. You know, so first of all, measles are on the rise, MMR or vaccinations are not where they need to be. Where does the capacity for that generally sit? Primary care. So there's a whole set of other things that are going to come at us and new problems that we're going to need to solve. There's also a danger that we kind of, John's talked a little bit about elective recovery from a slightly different perspective today. And there's also a real danger that we kind of fall into the trap of thinking this waiting list was not here before the pandemic. This waiting list flipping was here before the pandemic. It's just made worse because of the pandemic. And actually, we were talking about the problems that creates in primary care around pathways and capacity before all of that started to hit us. So there are risks here around, there are new pressures that we're going to face as a consequence of the pandemic through a hesitancy of vaccination, but there are existing pressures that were here before the pandemic around waiting lists, and we need to not forget that that's the case. I think what we need is innovative solutions. Our biggest Achilles heel, I fundamentally believe, is digitisation of primary community services. I don't think everything should be online by any stretch of the imagination. Absolutely, there are people within our communities who are either of a certain age and not technologically savvy, or suffer the consequences of deprivation and poverty, and who don't have ready access to latest technologies. But we can't expect to continue with a model of care that is based on walking through the front door of a GP practice 100% of the time. We need to be more innovative than that, and I think one of our challenges and risks is our inability to keep pace with technological revolutions and support our primary care colleagues in a way that they need to keep as much in front of this as they possibly can. And John and I took some big risks right at the start of the pandemic with things like AccuRx. I fear we're going to need to make some even bigger risks going forward to make sure our technology keeps pace with what it needs to be to help alleviate some of the pressure in primary care. So that would be a kind of mirror of a few things that I think we need to think about going forward.
Yeah, thank you for that. I think my reflection on the list of things I have was we seem to be making some real progress in some key areas, and I'm just a little bit anxious that as we move into the GM-ICB model, that some of that progress might stall, especially as GM have not got round to appointing the senior leadership team yet, and we're so close to the date. And I'd hate to think that all the good work and effort that gets delayed, because that will have an impact on the patients of Oldham, which we don't want. And secondly, I think John and Mike have made really important points about, as we go back to, we're not going back to pre-pandemic models of care. We have to prepare and be planned for the future going forward to meet the needs of the population. And that obviously is really dependent on John as the clinical lead and Nicola commissioning services having, it seems to me, a very clear plan of the way forward. And once again, I'm anxious that we might not have quite the same flexibility in the new model going forward if this committee doesn't exist any further. So I feel better for saying that. And in the absence of any other business, thank you all very much. We are 1 minute past 3 o'clock. Declare the meeting closed.
Thank you.